Thanks for coming. Thanks for waking up early with me and experiencing the best and worst day of my life when I have to present, which is great, and it has to be on the week of daylight savings time. I generally am very chatty, as you can tell, in the mornings if you've been here over the last 3 or 4 years, and it's my first time presenting because I've ducked under the radar for a long enough time. I want to present. I've been thinking about what case study, what thing we could kind of share and collaborate on together. And low back pain came up. The title changed actually after last week's presentation because there was some misnomers that I think we'd like to discuss here about halfway through. But kind of coming into, I'd heard us saying that oftentimes when we go through life and we change, we have new eyes. And then when we have new eyes, we come back to these old problems that we've had, or maybe some of the similar things that we've experienced, and we can look at them differently. Right now I'm feeling like I've got some old eyes as I'm going through and checking this out, but we'll see what we can get together. Instead of the mailbox conversation that we have most of the time here when the patient comes up to you as you're sitting by the mailbox, I'd like to kind of maybe bring in a little bit more light, and maybe we consider that it's, instead of the mailbox, let's sit down on the beach and have a pina colada, and as we talk, this person comes up to us. And if you've been to Cabo or anywhere south of Utah lately, more than likely it's going to be you sitting on the beach and someone else comes up to you and they're Canadian. But that was the experience I've had a couple times as we've gone through. But really, let's get down to the case presentation. So this person comes in, she's a 39-year-old female, had low back pain since 2020, so it's 5 years now that she's been having it. She's got pain into her legs, or not pain into her legs, excuse me. She can't stand for very long periods of time. Car rides worsen it. She states it's painful when she leans forward. That's her back index when she comes into the clinic. She says that she's had back pain most of her life. I've done many rounds of physical therapy and chiropractic work through the years. I've had 2 rounds of cortisone shots and radiofrequency ablations. She's done hair for a living, and the back pain became too much that she had to quit in 2022. She still hasn't found much relief, and she says that she feels as if she can't move without stretching at the beginning of the day. I've had difficulty doing simple tasks such as dishes, or laundry, or other things. What questions, or what are you guys thinking as far as what's going on with this patient?
I'll be honest, when I see someone like this come in, I just want to see images right away.
Okay. Why is that?
They've had several treatments, and just want to see some current things that have been done imaging-wise. There's a lot of things that are not commented on imaging that probably playing to something that's had pain for several years.
Yeah.
That's what I want to see.
Cool. Anything else?
The pain with flexion kind of makes me lean more towards anterior column pain, so discogenic or basivertebral nerve pain possibly.
Yeah, I like how you kind of like can separate some of the like anterior versus posterior pains, things like that. It's a good way of thinking.
So currently doesn't have any pain in her legs? Any leg radicular pain in the past either side?
Not that I found out when we talked with her. Didn't have anything down there. Any other questions you might ask her?
Does it radiate to the front?
Didn't say that. Nope.
What stretches relieve it?
She would lay on her back, knee to chest, like piriformis stretch. That's what she had said. And that was about it. When she said stretches, there weren't really a lot of stretches, even though she said she'd had physical therapy. So.
Did she get any relief from the cortisone or ablations?
No. She didn't say. If they did, her comment was they didn't work. I probably could dig in a little bit longer about that and say, well, did it work for how many months, or immediately afterwards? But from what she'd said, they didn't give her the relief she was looking for. Yeah.
Low back pain where?
Broadly,
Buttocks.
yeah, right above the buttocks, broadly right across here. You look, whoop,
Medication?
just like that. NSAIDs didn't work, and let's see, we're going to go into, in 2021, Eric, for you, She did have an MRI. That's what it looks like. Thank you, people who sent me MRIs. That was great. I couldn't access them on this side. That was the sad part. I didn't have access. It was like some other one. These are the other slices. Do you guys see anything that stands out to you? Since I don't read MRIs all day or with vigor or excitement.
L4-5 has a decent amount of fatty infiltration into fist muscles.
That's this here, right?
Where's the red arrow?
I was trying to actually find. I wanted to put like 5 or 6 in different areas just to say that there were red arrows. Didn't get to it though. Thank you.
Lots of red arrow.
Got you. I love that. Anything else you would want to ask her or know after seeing the imaging?
Is there any X-rays at all?
No. That's actually kind of knowing. And so this was a case we took last year and have been working on. And my spider senses too are like, okay, do we have flexion extension X-rays? I'd want that too. So she did go under. This is kind of like summarizing it, bringing it up. 2 radiofrequency ablations. We've got the epidural steroid treatments. Didn't change it. Muscle relaxants and GABA didn't help as well. It's kind of interesting that that was an issue. Any other thoughts of what you guys would do next?
What are her typical activity habits? Is she active? Is she pretty sedentary in general? Or what's...
Yeah, she's fairly active. She wants to walk quite a bit. She can't because of the pain. She was a hairstylist, standing a lot, moving and being active, accommodatingly active throughout the day. By the time she came to see us, this is 2024, now 4 years into the pain and suffering, not as active anymore. She's put on weight, she says. She didn't feel good about that and wanted to be able to change that. So kind of had the right mentality of wanting to be active, but couldn't because of change in pain. Go ahead.
I think it's interesting when we look at this because we'll hear that from the patient, like, I've done chiropractic, I've done physical therapy. And so I think from the medical provider standpoint, they're like, oh, well, I can't send them back to physical therapy because they've already said that they've done physical therapy. But we don't know if that's one visit, one evaluation,
Right.
got somebody just needed chest stretches, or even saw chiropractic once
Yeah,
or twice.
not a plant. Very good, because
Which is funny because I didn't treat these patients.
no, but
I'm learning with
it did bring to mind. I mean, we have to look at this patient now. If we just do the same thing as we've done before, it's not going to serve her well. It won't help her. She's had at least, so I'm the conservative care here, right? I'm the physical therapist, and they're in my office. What am I going to do differently? How am I going to treat this patient when everything hasn't worked? Brad?
One thing to consider is some people will say they've done physical therapy, but it's like I YouTubed a bunch of stuff, or I did what my neighbor told me that worked for them, and then they call it physical therapy. I've also seen that there's some chiropractors that do physical therapy in their clinic, but it's not with a physical therapist. Right? So ultimately, like, what kind of physical therapy did you do?
Yeah.
What did help, what did not help?
Yeah. Even with she did mention chiropractic care as well. So she's doing that or doing chiropractic care, and that's not helping either. And if I share space with a chiropractor and we look and we see we can complement and treat fairly well together, and if you're helping a joint move, if you're helping them get stronger with physical therapy and you're combining both, chances are it's going to work if you're doing the right thing to the right joint, to the right tissue. So that's kind of where it piqued my question. Anton?
There's been quite a bit of literature for somebody who's kind of been through several things about just what they call treatment preference, right? So what do they think is going to work for them? And I'm just curious, did somebody ask her, what do you think might help fix this problem?
Yeah.
Whether it's more physical therapy or a chiropractor or a shot or what's next?
Yeah, I love that question. In the end, you'll see kind of one of the summary points is buy-in. You've got to create that. I didn't ask that question. I actually asked the antithesis of it. if all of those things didn't work, let's try something new. And that kind of changed the dynamic with her as well, where she was like, okay, maybe there is something out there. And I was trying to be as creative as I could. And having worked with Summit, having worked here in these rounds, new ideas are constantly coming to us. So I think that's where I started looking at my physical exam. So then I looked at her motion, looking for what I was thinking and biasing towards apparent movement, where as you bend forward, maybe there's a hitch or something as they go down. And as they come up, they have to drop their knees and come back up. We would call it lumbar instability, but knowing that the spine, the stability part, I hesitate to kind of label that now after last week. That was kind of the idea there. If we're calling something less stable, it becomes a little fearsome in patients' minds. So I'm not going to directly want to throw that out there to them. I'm looking for painful static positioning. Does the system of the spine, which is supposed to be a protective unit and control things, does that have an inefficiency? Is there a problem with that? Does she have pain with extension, meaning she can't move? Do the facet joints not glide appropriately? One of the tests that might help me and help us in diagnosing things would be a prone instability test or a prone endurance test, looking at actually the quality of the muscles, because I think someone was pretty adept at seeing what's on the MRI. Once we got that imaging, what's going on with that muscle? And then palpation. Is there difficulties in creating muscle contraction, and are there issues, trigger points, or other parts of that muscle that's supposed to be long, smooth, and correct? Is there going to be issues there? Then also, I think one of the parts of the physical therapist side of us that we look at this lumbopelvic strength is the muscle or the lateral support structures like the hip abductors. Are they strong? Do they move? Do the glutes help to actually provide a hinge movement, or is it all through the lumbar spine creating more problems? Did I miss anything else? As I was trying to go through, I'm sure there's some things in here, but this was at least what I looked at. Would you guys have added anything?
So what was your diagnosis?
Multifidus insufficiency. And based on this being positive, right, this is how we're going to take our prone instability test. It's not stabilizing. Something isn't there that's helping that system. As I pushed down on her back, it was painful. And as she extended her back and engaged those muscles as best she could, they weren't as painful. Let's get into that, Eric, because I like that question. So
there's a lot of hypertrophy on the ligament flavum in that MRI.
Mm-hmm.
Plus a lot of
on that, it was on the left side, right? Let me run through.
So you have a grade 3 there. It's a pretty bad infiltration thing. No, not necessarily.
These are the 2L4. What are you saying?
There's enough to where you push on that area, you're going to get some.
Yeah.
And that's the question. There's a lot of fat infiltration there, so you can do a lot. It's going to be. We use the word unstable,
Mm-hmm.
but if you're trying, maybe that's not a correct term for this, or just some instability of functioning.
Yeah.
We can get creative on some different things with it, but when she bends forward or bends backwards, it's going to hurt after a little bit because there's not much support there, and that multifidus muscle. The question is, how did it get there?
Yeah.
Why is it only that level? There's it's a little bit less on 3-4. If you go to 3, I bet it's going to be a little bit better.
What causes multifidus atrophy?
There could be some arthrogenic reflex inhibition, so there was some sort of injury to that joint at one time.
Mm-hmm. So code for pain at that area, right?
Start a cascade of events of that tissue declining.
Mm-hmm.
And that's why we do have some different procedures that are coming up really popular, like peripheral nerve stimulators or something like that, to try to get going. We've had this discussion of what is a good treatment for this diagnosis, but it's one that's going to be it's difficult to deal with these women. She's still functioning.
Yeah.
She's still going to work.
No, she quit.
She had to quit.
Yeah, she quit work because of it. We did talk last year about an implantable, and that's kind of what's been mulling in my mind about it. There's an implantable way to treat this, And this is the dysfunction or the problem that we're looking at because of pain, because and that's the harder part, was I didn't know how to fully treat the pain causing this symptom. But the reverse, in a way, is kind of what we started to dive into and look at, was something shocking to try. So instead of running the implantable one, not licensed to do that, happily not licensed to pierce the skin. It's great, my patients love that. There's been a bit more research in this. Just came out, if you can see, American Journal of Physical Medicine Rehabilitation in February of this year. We've known about it, and we were trying to find more ways. We're studying multifidus atrophy and other stuff, but this group took two groups, one exercise and one exercise plus NMES. Now, I didn't dive in enough. I couldn't get access fully to it. I only had the abstract, so I do want to read more about this. But what they found next time, it was a night. I'm sorry. I'll get access to it, and you guys can all read it with us. How's that? Research, it's great. Love it. It's awesome. But what they did find was the group with the NMES had more muscle thickness following their treatment pattern, leading to then what we'd say hypertrophy of the multifidus muscle. And as we go back and see, it's kind of interesting tell me if I'm wrong or anything else, but healthier muscle would look like this, right? Psoas from the inside. It's a nice stark comparison to see, here's fatty infiltrate, less effective muscle. Psoas, that's stabilizing from the anterior side, more than capable and or healthy. So that's what we wanted to end up looking like. Okay, let's run back. I just love that picture. Anyways, so now we're going to run into, this is what the pathway that I ran down with her on, was to create, and we've done this for knee pain for years since I've been practicing. Like, you get an atrophied or insufficient knee, hook them up. It's called Russian stimulation. I mean, Rocky IV, it's like the greatest movie, second greatest, one of the best ones here. That guy, he was so oiled up, I don't know how the electrodes stuck. Nevertheless, it was a great thing. And here he is getting shocked, and he's getting huge. We do that to the knee, and it's like I walk into the patient, the first 3 days after an ACL, and I'm like, okay, shock and awe, here we go. And they're like, wait, what are you doing? And I'm like, it's fine. Slap 4 pads on. And I look at them, I'm like, I'm going to hit the Russian setting. Is that okay with you? The pain meds are still kicked in, so we're okay. And we turn it up and we activate the muscle. But the problem is, and I guess the concern will be, that's an outside going in feedback loop. And in motor learning, you want to have motor programs that are inside out, from the brain down through the nerves into the muscles, rather than the muscles feeling the nerves going up to the brain and getting that sensation. So the key for this treatment will not just be putting the pads on, doing the treatment. And if we can see here, this is a setup at least of what we're using. We're using a small little handheld device. You also have the big Dynatronics. There's a couple other ones. But the difference being, it's not a TENS unit, and patients will come in, I got a TENS unit, it's fine. The waveform on this is a bit more wide and it's lower. So that way it stimulates the motor units versus the higher frequency ones, which just kind of go across the top of the skin. So I sped it up. I found someone to edit it, which is amazing. That was me. Thank you, Google Photos. So there's us turning it up. As you see, it's going to be a little bit harder, but if you can look, kind of watch right in here, you're going to want to see the muscle belly itself twitching. And we know that's great. So then on this one, once it's activated, then he's going to create a muscle system. And I didn't think the stereo would work. Let's hope he doesn't hear it. Okay, moving on. Said some things in there I didn't want to repeat. That's great. There will come a time when on this system, it's kind of fun, we tell the patient, you're going to squeak. And they're like, wait, what? And once it gets from the priming motion to the actual contraction motion, there's usually a bit of a jump and an excitable moment in their life when that thing will kick on. At the office, I'm very famous for having it on my leg for doing quad sets or something like that, and I squeaked, and so it's kind of stuck. But in addition to the NMES thing, I think what we really need to bias ourselves and work within is controlling it. And what we found with her, we'd put the NMES on her, have that work, and then I'd get her up afterwards, 20-minute treatment, have her bend forward, have her move backwards, give her the encouragement and the engagement of, okay, these muscles that we just woke up, you need to use them now in an appropriate way. And so I'll kind of run you through just fairly quickly different exercise ideas, PTs in the room. We know we'd start with the table first because it can support the back, and where the table is, it's stable. The table is stable, and so we start there. And we don't let them graduate until they can adequately manage their upper extremities or their lower extremities in that fashion without losing that lumbar control. And we're engaging that while we've educated them now with the NMES. This one here has been tried and true. We've used it for 20 plus years. I'm not sure exactly how we figured this out, but if the multifidus is an extensor and a rotator, having the knee on an opposite side, you use your lumbar spine to extend and rotate the pelvis in this fashion. Here's low, here's high, and you're bringing the pelvis up to an equal distance. It's really great to tag that in, and it's a little more aggressive against gravity than it is laying flat on the table. When they've mastered that, then you get them sitting. You can use unstable surfaces on the chair or on the floor and start advancing the exercises that way. And once that's good, you're able to create more of a chop variation, which is more what we do in life, bending down and picking up, holding themselves upright. What happened to her? Just checked in with her yesterday, actually. Asked her to fill out an ODI because I didn't get one on discharge. She went down from a 42% impaired to a 10% impaired, having done the exercise. She did end up buying a home unit, but she also knows that there is an implantable one and or other methods to help stimulate that multifidus weakness. And when she fails, this is the other curious thing, when she got lazy, maybe she actually she moved to Nashville, I believe, and then back. And in that movement time, she wasn't as religious with her exercise or consistent with it. She noticed her back pain increased, had some more problems with it. So once she got back onto that and worked on treating that multifidus dysfunction, she was able to then stay pain-free. She has very little pain right now. She's back to doing all her ADLs and being fairly successful. So,
After work?
Yes, in her way that I don't think she's doing hair anymore, but she's having great time.
How long was that treatment plan?
That was 2.5 months. It was twice a week for 4 weeks, and then once a week for 4.
We don't have any post-MRIs to see if there was any improvement.
No, I'd like to.
Be good stuff.
Yeah, it would be. We need to find an MRI machine.
Do some research.
We could do some research on it, and that would be even more fun. I love research. It'd be great. Things to consider, guys. So this can't be, especially with multifidus dysfunction, I don't really think it's going to be one of those cases that you could just go to PT and get it all done. I think you need to be able to manage their pain, and you can do that with all of the group that we have here, pain management, chiropractic care, physical therapy. We all need to work together to address these adjacent segment issues. If she's tied up top in her thoracic spine, it is going to put more pain and problems. Like we talk about what was the etiology of it. We're treating just the symptom of multifidus dysfunction, but there could be some spinal issues going on. Consulting and working together is key here. We need to get their buy-in. The patient really needs to understand, and that's where we come in as educators. We need to be able to explain to them what's going on with their back, why this is a problem, how this works, how it got here, because they'll have that question like, what's the diagnosis? What's going on? And you can explain that to them and get their buy-in, because they're going to need the encouragement and manage their outcome expectations. You got to tell her, look, if you stop doing this, your pain's going to come back. It's going to be a great cage at some point in time if we don't, manage this and pain becomes too much. So getting that long-term buy-in is going to be huge. We've got to be able to understand that and trust the process. Both of us as practitioners, leaning into taking care of them, understanding them, asking that question, Anton. That's awesome. What do you think will work? What hasn't worked? And understanding, okay, now if these are all things that have been done to you, how about we try something a little bit new? And maybe this new perspective of electrotherapy that we've done on the quad, let's start doing it a bit more on the back and see what happens, see if we can change people's lives. Thank you.